Thank you for joining us today on Matters of Substance. This is Carly, your host, and today I have Caitlin with me. Hello, Caitlin.
Hello, good morning.
Yes, we are so happy to speak with Claudia Wojciechowska from the Indiana State Health Department. She is the Drug Overdose Prevention Program Director and works for the Division of Trauma and Injury Prevention. And we're so excited to have you with us today, Claudia. Thank you for joining us.
Of course. Thanks for having me. I'm really excited to be here.
Oh, excellent. So I know that we've chatted a little bit prior to this recording, but we just want to kind of talk about what you guys have going on over there. You have so many programs, and today we're going to discuss a few that are going on. And so, if you would, why don't you start us off with sharing what ECHO is?
Yeah. So I want to kind of back up a little bit and just maybe generally talk about what funds ECHO. So we, about a year and a half ago, applied for a federal CDC grant called Overdose Data to Action. And it is about $21 million 3-year grant. And it really focuses around substance use prevention. And within that grant, there's all of these categories that you kind of have to hit. There's data surveillance, there's harm reduction, there is things you have to do around providers, so healthcare providers, things you have to do around the PDMP, which is the Prescription Drug Monitoring Program. In our state, it's called Inspect. And so Project ECHO is one of the activities that we fund under one strategy. They're called strategies. Out of the, 15, 20, 25 different projects that we fund. And specifically, Project ECHO is something that started at the University of New Mexico. I don't remember when, but several years ago. And it really started around hepatitis C. And so there was a physician who realized that in the state of New Mexico, there weren't enough providers who were providing care around hepatitis C. And so he started this kind of video conferencing teaching platform in some ways, where he would have kind of a hub, kind of an expert panel of Hep C providers. And then he would invite physicians who were not Hep C experts, so a lot of primary care physicians, on a weekly basis, and would teach them how do you treat hepatitis C. And the whole point of this was to kind of train more primary care physicians to become Hep C specialists and to be able to treat hepatitis C across the state. And so it really started with that, just one particular disease. And then he replicated this model for a lot of different diseases, but also for example, the ECHO is a non-clinical model. And there's a whole lot of evidence behind it. They did a ton of studies, and this is a really effective model. And so now at this point, several years later, there's probably an ECHO in every single state and internationally. There's ECHO for autism. There's ECHO for harm reduction. There's ECHO for HIV. And within the state of Indiana, there's always, in every state, there's an ECHO hub. So there's some kind of organization that leads ECHO. And in the state of Indiana, it's the Fairbanks School of Public Health. And I know also the Ivy School of Medicine does also ECHOs, and I think they work together, but they tend to have different focuses. And so Project ECHO, the one we fund, is called the InCares ECHO, Indiana Communities Advancing Recovery Efforts, and it's a non-clinical ECHO that focuses around substance use prevention. And so we have what we call a hub, so that expert panel of substance use prevention experts. And then the folks that come together are not clinical physicians, but are actually, in fact, communities, prevention coalitions, that come together on a monthly basis, and each sort of ECHO meeting consists of what they call a didactic, so some kind of expert-led PowerPoint presentation. And we've done some on medication-assisted treatment. We've done stuff on harm reduction. The last one we did was on legislative updates regarding substance use prevention, or just substance use in general. And then there's also always a case presentation. So some group, some coalition that comes in, then presents, here's an issue that we're having in our communities, and we, as all of the communities, the hub experts, come together and provide thoughts, feedback, ways to move forward. So it's a model that really tries to provide solid and just like tangible things that communities can actually do to improve substance use prevention efforts in their communities. And so we've been funding this for about a year and a half, and it's a new model. So like, for example, the hepatitis C has been going on for years and years, but this is something new. We replicated this from Maine. Maine was the first state to do this. And we thought it was a really cool idea, and so we brought it to Indiana. And each of the communities not only participates in this monthly learning community, but also has actual funding tied to this. So they can learn about, best practices for substance use prevention, but they actually have dollars that they can then use to implement those strategies in their actual communities.
Wow, that's amazing. There's so much going on with that. Okay, so how can somebody listening right now, how can they get in reach with getting signed up for one of these seminars?
Yeah. So for now, a lot of the echoes tend to be closed, tend to be open rather. So anybody can join. But with the InCares Echo, we decided to keep it closed. And we say that because each community already has, I don't know, sometimes 10 to 15 to 20 stakeholders, and there's 16 communities. So it's a lot of different people. And the Echo really doesn't function well with more people. And so we don't tend to invite outsiders only because we want to make sure that people actually get something out of it. And if you can't participate actively in it, it doesn't serve a very good function, if that makes sense. So we tend to keep it closed to only the communities that are apply and funding and that apply and are funded. But we do have a new grant opportunity that's coming out this spring, so pretty soon. We're new, and it's open to a lot of different people. Hospitals can apply. We have substance use prevention coalitions. We have treatment centers that apply and can be a part of it. And so it's kind of open to a lot of different stakeholders. So folks are listening and they are part of a coalition or some kind of group that already do substance use prevention work. They will be eligible to apply.
That's amazing. So, say like you guys cover all of Indiana. So, anybody from Northwest Indiana down to Southern Indiana can apply as long as they're as a part of one of these groups or have some kind of community connection.
Yes. And we tend to really encourage a lot of stakeholders to come together because it really is supposed to be an interdisciplinary approach to implementing substance use prevention in your community, right? And so we encourage communities that apply or coalitions that apply to have a broad range of stakeholders. We love to have law enforcement on. We love to have people who do substance use prevention, people from schools, people from the local health department. And that's, so in some communities that's possible, in some communities it's not, but we do encourage this to be an entire community effort and to bring a lot of stakeholders to the table.
Wow, that's so amazing. I'm so happy that we have the opportunity to talk about this because I don't know a lot of people know about this opportunity. And so it's great that people can hear about the opportunity that they have, not only for this grant funding, but also just in general of like what this program looks like, what Echo looks like, and how you guys are really working to better the communities of Indiana and give them the best tools possible.
Yeah, and a large part of also the Echo is to connect communities to one another, right? And so when we were picking who we would fund and be a part of this project, we didn't really be mindful about, we want to have small, low capacity counties. We want to have high, larger capacity counties to also be able to learn from each other. And there have definitely been instances of, a county learning something a neighboring county is doing and then replicating it in their county. Or people, across the state saying, hey, you and your community have a harder time talking to law enforcement. We have somebody that can help with that. And so whenever I see those moments happen during the actual Echo, those are like the little gems that make me really happy. And I'm like, this is what was the whole point of this project too, was to connect communities, have communities learn from each other what's working, what's not, and to have communities brainstorm the issues that they're facing. And because so many of them share the same concerns, right? Working with law enforcement in this field tends to be difficult across communities. And so how do we work through that, right? How do we get law enforcement to the table? How do we form good partnerships with law enforcement, for example? And so those are things that communities really can come together and brainstorm and work together.
Absolutely. And I think just like from experiences here in Porter County, we have a very active law enforcement community, which is wonderful. But from different opportunities where I've talked with other people, that's not necessarily the case in every county. And I can see how like connecting with one of our neighboring counties, if they don't have that kind of presence, giving them some tips on how we've been able to build that relationship would really be helpful. And I'm sure there's areas that other counties around us have like more commitment from other sectors that we could learn from as well. So I see how that's a very beneficial structure to have.
Yeah. And we are currently, I do want to highlight that there's a lot of money on the table. We have about 1.5 million that we subgranted the first year to 16 communities, and we have another 1.5 million. So if anyone's listening and has a coalition that wants to apply, we do really highly encourage folks to pursue the grant opportunity. And there's a lot of things folks can do. We have sort of strategies that we fund. There's like primary prevention and education, right? So going into schools and providing education. There's linkage to care. So connecting those who already have substance use disorder to wraparound services. There's data collection that we fund. And so there's really a lot of different, innovative and evidence-based things that communities can do with this funding.
That's awesome. And so like when somebody's applying, I guess if we give a little tidbit, like do they need to have an evidence-based program or practice as the driving like piece of their funding, or is there anything like that that they need to kind of be mindful of as they're thinking about whether or not they want to apply?
Yeah, that's a great question. So this is CDC funding, right? And CDC always is trying to push evidence-based practices. So for sure, we really want to fund evidence-based practices, but we also want to recognize that sometimes what passes as evidence, like it takes a lot for something to be considered evidence-based, right? And so, for example, mobile response units, there's a lot of them are across the state and across the country, and they've shown a lot of positive progress, but they're fairly new, and so they don't necessarily have the huge evidence base that a lot of other programs have, but it doesn't mean they're not worth funding. And so we do want communities to have, evidence-based programs. And when I say evidence-based, what I really mean is like, for example, BOTS and Life Skills. That is a prevention program for elementary schools that is approved by SAMHSA and endorsed by SAMHSA. So that's something that's called evidence-based, and there's a huge amount of literature behind it that it works. Mobile response units don't have as much evidence, but they're still worth funding. And so we do try to do both, right? We want to definitely fund evidence-based things, but we also want communities to have the flexibility to do innovative work. And so we encourage, folks to apply for both. And there's certainly things that we don't want to fund or sometimes things we can't fund. We had communities apply for drug take back. Unfortunately, that's literally not an allowable with the grant. And so communities that want to do drug take back events, that's something that's not allowable. But we funded such a wide range of activities across the state. Whenever folks ask me, like, what are you funding? I'm like, well, what county? Because it's really different in every single county. And some counties are really focused around linkage to care and wraparound services and peer recovery coach. And some counties really focus most of their efforts on doing primary prevention, whether that's in schools or at the YMCA or what have you.
I love what you said there, that basically alluding to that just because something isn't evidence based doesn't mean it doesn't have value. And so
Right.
I really like that mindset can be used moving forward with this grant funding, because sometimes there is a lot of restriction, or maybe not restriction, maybe that's not the best word, but there's a lot of focus placed on evidence based, and like you said, it takes so long to get something evidence based, but that doesn't
Right.
mean that it's not valuable and that it's not helping the community. And so I really appreciate that you guys have something on the table that doesn't have to be just based on the data, but you can also say, okay, we're seeing that this is a mobile integrated response team is really beneficial for this community. That's why we're going to fund it.
Yes, exactly.
Yeah, and something I thought of, this is Caitlin, is that when all programs at one point or another were new, and they all had to kind of build their reputation to become evidence based. And I think with certain programs like mobile integrated response teams, sometimes it just takes a while for them to, to prove their efficacy and things like that, so that more research and more studies can be done to show that they are evidence based, or it is evidence based, or that it is something that creates lasting effects that are worth funding or promoting people to do. So yeah, I think it's good to give it a chance so that we can actually get to
Right.
know, is this working?
And it becomes this cycle of, we're not going to fund it because it's not evidence based. But if you don't have funding, how do you even get the program running and show that it has, some sort of
Exactly.
positive impact?
I love this little piece of conversation here because we don't really talk very often on this show about like what a program evidence based is and like what it takes, and that's really such an important element of everything we do. I know that obviously we always want to make sure that whatever we're implementing in our communities is effective and is going to have, like Caitlin said, a lasting positive effect. Of course, that's what we want. But going back to your point, Claudia, if we don't fund people to see whether or not this program is effective, well, it'll just be a vicious cycle that we can't get past. And I really appreciate that we're giving listeners the ability to kind of have a look at that right now because we don't often talk about that. So let me ask you. I hope you don't mind if I shift gears just a tad bit here. I know that you have shared with us about Project Shield, and I just really want to make sure we have some time to spotlight that because I think it's a really cool program that you guys have going on. Would you mind sharing a bit about that?
Yeah, I'd love to talk about that. So I did touch a little bit earlier that, communities sometimes struggle to work with law enforcement, and we as a public health agency also struggle to sometimes work with our public safety officers. And a lot of states across the country really struggle with that too. And so when we found out about this program, we decided to fund it. And so SHIELD is, and I forget what it stands for, but it's a program out of the Northeastern School of Law, out of what they call the Health and Action Lab. And it really came out of a body of research that showed law enforcement basically need more training around occupational safety and around harm reduction when it comes to the opioid epidemic to be able to be more effective in their jobs. And so they created this training that they first launched in a few states, and we brought it to Indiana recently. And so we funded them and we gave them money to basically tailor the training to Indiana, tailor it to Indiana laws, tailor it to sort of the political, social environment in Indiana, and to also bring on what they call Indiana ambassadors. So the training is not delivered by me, and it's not delivered by the Northeastern School of Law. It's delivered by people who do substance use prevention work and law enforcement themselves. And so we have a few Indiana ambassadors. One of them is Brandon George, who works in the Indiana Addictions Coalition. So he does a lot of work around peer recovery coaches and addiction work in the state. We also have Madison Weintraub, who works for the Marion County Surveillance Service Program. We have several law enforcement, including, for example, Captain Kevin Hunter, who works at the Fort Wayne Police Department. He works in narcotics. And so we have a lot of law enforcement officers. We have one who used to be a chief in Vermont, in Burlington, Vermont. And so he's also one of our kind of outside partners. He's not from Indiana. And, a lot of the training is law enforcement talking to law enforcement about these issues. And it touches on a lot of things like again, I said, occupational safety, harm reduction. We have incorporated some COVID-19 safety in there, and it's about a 3-hour training, and we've done, I think, 3 different sessions of them, and we've also partnered with the Indiana Law Enforcement Academy to be able to offer, they're not CEUs, but they're kind of similar to what law enforcement, the kind of like learning credits that you get when you tune into something, to be able to offer those for law enforcement who tune in. And we've had pretty good participation from across the state. The training tends to be engaging, and we are also we've had pretty good success on it. We're evaluating the program, and we're going to continue to do evaluation on it and to make sure that it's actually working and that law enforcement are getting out of it. And so part of the evaluation is doing kind of like a baseline survey with law enforcement, and then doing one after the training, and then doing one, I believe, at 3 or 6 months later to see if, any of the knowledge that law enforcement gained during the training actually stayed and was implemented in their, everyday work.
Oh, I love that you guys are doing a second follow up to evaluating that because I sometimes feel like programs that are implemented, like you do an evaluation right off the bat, but then like if you don't do one in 6 months, you don't know the impact it had, longitudinally. So it's like really, I love that you guys are doing that. I like that you're gonna follow up and see, was this useful, and if not, then you'll have the ability to kind of change up what needs to be changed. So how does somebody, if they're interested in in signing up for this, a law enforcement agency, who do they contact? Who do they call? What's a good email?
Yeah, so well, they can contact me, but we've been really trying to promote it. And so we are partnering with two universities. It's not only Northeastern, but it's also Wayne State University in Detroit, Michigan. Wayne State University are our evaluation partners. And so they evaluate a ton of our activities within this grant, including the SHIELD program. And so I'm happy to pass on the link. It's publicly facing and and it's really tailored to law enforcement. Other folks have sat in on it. We've had some harm reduction folks, even at the Department of Health, who have sat in on it, but it really is tailored to law enforcement. And so we do encourage mostly law enforcement to sit in on the training, but it is open to anyone. And it's, again, and I think if you Google SHIELD, Wayne State University, you could probably find it.
Okay. And I do believe, I think it's on the Indiana State Health Department's website as well. I would assume it is. And I feel like I looked at it there earlier. So that'd be a good place to start. So this training is 3 hours. And is that all at one time, or is that like say every other day or every day, 1 hour piece?
No, it's just a 3-hour training all at one time.
Okay.
Usually it's in the morning from about 9 a.m. to 12 p.m.
Okay, perfect. Yeah, I just kind of wanted to maybe make sure that what you guys are training on is briefed over again. So I know that based on what I have found, you guys talk about overdose crisis and COVID-19, which I think is really important because right now we're still, in that pandemic. It may feel as if things have kind of loosened because we've been living with it for so long. We're still facing barriers because of COVID-19. And I really appreciate that you guys are taking the opportunity to help law enforcement understand kind of like how COVID-19 is impacting overdose and that kind of like whole realm of things. That's really important.
Right. And it's also impacting like the actual occupational health of law enforcement too. And so we have 3 modules within the training. And so module 1 is the occupational health and wellness. So it's literally focused on safety, on things like needle stick injuries, right? When you're at a site when somebody has overdose and there's needles around, how do you maneuver that? And especially with COVID, right? If somebody's overdosing and they need CPR, but we're living during the times of COVID, right? And so that poses additional challenges. Module 2 kind of moves into policies and procedures, so actual laws related to paraphernalia and naloxone. Because the SHIELD folks at Northeastern found that a lot of law enforcement are not exactly super familiar with the laws, especially drug laws are constantly changing. And so how are you as a law enforcement officer able to even keep up with the constant changes in laws? And then if you're not familiar with them, how can you police them, right? How can you actually implement them during your job? And so it provides kind of an overview of policies and procedures related to that. And then the module number 3, it moves into what we call public health services and integration. So it offers law enforcement access to resources and treatment. And I want to share a little anecdote. We had a law enforcement officer who, has been in law enforcement for 25 years. And his feedback was like, some of these resources that you all have shared with me, I have never seen in my 25 years of policing. Like I didn't know that I could take someone to treatment, or I can create wraparound services for them that really don't put a lot of burden on law enforcement, but that, maybe keep people out of jails or really connect people to services that they need. And so that was like a really positive anecdote that made me smile that day, because I was like, this is awesome, and that's the point of the training, is to also give, law enforcement the tools that they need to be able to maneuver, policing during the opioid epidemic.
I really agree with that. I think it is important for law enforcement to be as knowledgeable as they can be on these things because, as it was stated earlier in the episode, sometimes it can be difficult, working with law enforcement. There are barriers. There is sometimes a lack of understanding between law enforcement and, what we do, who we are in the prevention or treatment, recovery world, social work type of worlds. And when the two combine, it can be a great thing. if we can have all of, like you say, these wraparound services where everybody understands and everyone is aware of as much as they can be to help people, but sometimes it can also be hindering as well. So I think this is like one of the most important things we can do to assist law enforcement and thus create a pattern of assisting the people we're trying to serve.
Exactly. Yeah. And the training is also really strategic, and it has mostly, I mean, I mentioned the Brandon, George, and Madison White who are obviously not law enforcement, but it predominantly has law enforcement trainers. And I think the message is so much better delivered. You know, doctors listen better to doctors. Social workers will listen more to social workers, and law enforcement are more keen to listen to other law enforcement. And so I think we were really strategic in making sure that the quote unquote ambassadors and the trainers were really the right people to be able to deliver this training.
I think that's really great too. I totally agree with that. Sometimes we have subject matter experts trying to teach a whole different population of people something that we want them to know, but we're the subject matter experts, or vice versa, and sometimes it just doesn't relay. It doesn't click in the best way possible because it's not coming from necessarily a peer.
Right.
So I think that's great to actually be strategic with that and pick the right people, as you said.
I think that's to that point. I think that's one of the things that's really important too when we're talking about youth prevention. Like, so often we see really great results with youth prevention when we have peers implementing whatever that strategy is. And so I guess that's just to kind of highlight that, yeah, exactly what Caitlin said and what you've mentioned, peer to peer is so beneficial. So I also have one more question about the SHIELD program. And if you guys in that program, I'm going to assume that this might happen, but please let me know. Do you guys teach about naloxone in that? Because obviously that's a opioid reversal. Thank you. Reversal was right there.
Opioid overdose is also good. Yeah.
Yeah. So, do you guys teach about that in this program?
We do, yes. So we cover naloxone. We cover things like where to get naloxone, how to carry it, where to store it, how it works. So it's kind of a short naloxone training because there's a lot that goes into naloxone, but it just very kind of brief general overview of naloxone. Yeah, I think how it works, how much of it you need to deliver. The one thing I do want to say is naloxone myths. There's a lot of naloxone myths out there, and so this training also tries to dispel that. And one of the myths that we hear a lot is, for example, Narcan parties. I don't know if you've ever heard about this, where
No.
supposedly folks who use drugs get together and then they just have naloxone. So if somebody, they take as many drugs as they want because they have naloxone, and so they know that they can use naloxone if they happen to overdose. And it's really a myth that I've heard a lot. And so this training also tries to dispel that that's not really true. People don't intentionally try to overdose. Also, administering naloxone puts people in withdrawal, and that's really unpleasant. And so nobody really takes naloxone because they want to. And so it tries to also hit on those myths that a lot of police officers might have heard of. There's also a myth that's not naloxone related, but it has to do with fentanyl, that if you touch fentanyl, you will overdose. And so there's a lot of, and I've even seen like press releases from law enforcement agencies saying, don't touch naloxone, you will overdose. And that's also not true. You cannot overdose from physically touching fentanyl. You really have to inhale it, ingest it in some way, shape, or form, but it getting on your skin is not going to cause an overdose. And so it really also tries to touch on things that, might be common myths in the law enforcement community that are not exactly true and that are sometimes harmful, right? If you're scared of fentanyl, maybe you won't administer naloxone to somebody because you're scared of approaching that person. And so it tries to really dispel, those kind of myths and false beliefs.
I do have a question. As far as with fentanyl, you mentioned touching it, you cannot overdose. So is there an effect if you do just physically touch it? Is there any kind of effect that can happen that isn't necessarily an overdose, but some kind of adverse effect from that?
So I can't really speak to that 100%, but not that I know of. And I've seen also Department of Homeland Security. So our EMS agency in the state sits within the Department of Homeland Security, and they also put up a press release. This was a while ago when, they said, this doesn't happen. So please, don't, and especially they were specifically targeting EMS. But it applies to law enforcement too. Like, this doesn't happen. I don't know why this myth is kind of floating around, but there's really no negative side effects of touching fentanyl. It is not going to be absorbed into your skin. The appropriate thing to do is just wash your hands.
Yeah. I have to say thank you for sharing that, because even I believed that myth until just now, because I've seen it in the news, right? So I'm always like, oh, that's scary. I can't even be anywhere near it, or it might hurt me to some degree. And so that's just really interesting that that's a myth. And I'm glad that, you're sharing that, because honestly, I think a lot of people believe it to be true since it is in the news that way.
Yeah, for sure. And I think fentanyl in general is, pretty scary. I mean, it is a very potent drug, and so it doesn't surprise me that it's definitely a myth, and people are cautious around it, which makes sense, right? It is a very potent opioid. But I think we, especially folks who might come into contact with it, really have to be knowledgeable about what it can and cannot do.
Absolutely. And if you have somebody that is uh, has the intention to administer naloxone to somebody, say a family member who knows that, maybe they have somebody who's struggling with substance use disorder and they have naloxone on them, you don't want them, like you said, to be afraid to give that naloxone because they're worried that there may be a side effect. And so that's really an important thing for people to know and understand. Can you share a little bit about if naloxone administering it has any negative effects for the person that it's administered to?
It doesn't, not at all. You shouldn't, but you can even administer naloxone to a child, and it won't do anything. When folks overdose, sometimes you don't know what folks overdose from, right? You don't know if it's heroin, you don't know if it's fentanyl, you don't know if it's meth, whatever the case may be. And so we always say administer naloxone, because if it's not opioid related, it's not going to do anything. And if it is opioid related, then it's going to help that person survive. And there really isn't any side effects, any negative side effects, minus the withdrawal that happens. So if somebody is, overdosing from an opioid, it will put that person into withdrawal, and that's unpleasant, but it will save their life. But other than that, really, there's not much you can do. And even with, administering it to children, we have had cases of children overdosing from an opioid. They get into their parents' medicine cabinet and somehow ingest pills thinking it's candy. And we've had cases of naloxone being administered to children and saving their lives. And there's no negative repercussions except the fact that their life, has been saved.
And that's so important, I think, for people to know, right? Like, I think that there may be a hesitation when somebody's like, well, I don't know, am I going to be held responsible if something bad happens if I use this and administer it to somebody? I think people get a little bit hesitant about doing that, and to know that there's no negative effects from that, and that you could administer it to a child, an adult, and there's not going to be anything that's going to harm them from it. It will only, in fact, help them and save their lives potentially. That's really important for people to know. And so, if somebody is listening and they have a family member who is struggling with substance use disorder, or they just want to have this on them just to be safe in case they ever come across somebody who's overdosing, where can they go to get naloxone so that they can have that on hand?
Yeah, it's a great question. So there's a website called optin.in.gov, and it's a website that has all naloxone distributing entities. So by law, if you are distributing naloxone, you have to register at this website. And it has a statewide map. So if you type in your zip code, it literally will tell you where you can find naloxone nearest to you. And so you typically can get naloxone from a pharmacy, but sometimes your insurance will cover it. Sometimes you may have to pay for it out of pocket, but a lot of also entities give out naloxone for free. So at the Department of Health, we have a grant where we give naloxone to local health departments. So all 92 health departments across the state of Indiana are eligible to apply for naloxone from the state of Indiana. And there really isn't a limit to how much they can request. And then they give that naloxone out to the public. So some of them give it only to first responders in their community. Some of them have public naloxone trainings. It depends on the health department, but they all give that naloxone out for free. And so there's definitely ways to get free naloxone, but I do encourage folks to go to optin.in.gov and type in their zip code and see where they can get naloxone closest to them. And I did want to also mention, previously when you touched on, folks sometimes having hesitations, am I going to be held responsible if something goes wrong? And I also want to remind folks that there are Good Samaritan laws in the state of Indiana. There's one called Aaron's Law that does protect folks from, any legal repercussions if they do administer naloxone. And in the provision in that law states you have to, if you administer naloxone, you also please call 911. And so it encourages folks to, if you do administer naloxone, don't just walk away, call 911, make sure that person gets help, and you will be protected under the law. So not only is naloxone not harmful, but you also have legal protections that protect you from being, prosecuted in the event that something, for some reason, you never know, does go wrong. You are protected.
Thank you for touching on that. I had that in the back of my head and I meant to mention it and I didn't realize that I hadn't. So thank you so much for bringing that up because it is so important that people know that, that they are safe to help. I mean, this is all about saving a life. At the end of it all, if you have naloxone and you can administer it, you're saving a life potentially, and you are safe from any repercussions. And that's just a wonderful thing. I've heard that there's some cases where, and it's not completely uncommon, where somebody might need more than one dose of naloxone. So do you know anything about that? And if so, would you recommend people carry more than one dose, or what are your thoughts on that?
Yeah, that's a great question. I think, well, if you want to carry more than one dose, that's, great. But I, for example, just carry one dose. And usually, especially now where things are so potent, fentanyl is laced in a lot of different other drugs, you likely will need more than one dose of naloxone. But the important thing is if you administer one dose and you immediately call 911.
Great point, Claudia. And as we discussed previously, I just wanted to share with our listeners that naloxone begins to work within 3 to 5 minutes, but it can work anywhere from 30 to 90 minutes. So it actually extends past that 3 to 5 minute window, working from 30 to 90. However, if somebody doesn't respond within 3 to 5 minutes, then they should get a second dose or another dose on top of the dose they already had. And so that's just really important for listeners to know so that they can recognize when it's appropriate to administer the naloxone for an additional time.
And so we often tell folks, administer one dose and also do rescue breathing. Keep that person breathing until EMS or law enforcement get there and can take over the situation.
That's awesome. Yeah. So great suggestion. Make sure you're calling 911 because there is a potential of that overdose to come back again. There is a potential that, if you just leave it at that one dose, that the person may not survive. So calling 911 is so important. I mean, there could be a lot of other things going on within that person as well that you aren't aware of that they may need medical treatment for because of the overdose or because of whatever they may have ingested that caused the overdose. So very important. Still call the paramedics. It's just because they are receiving that one dose of naloxone doesn't mean that should be the last step of their care for that moment.
Yep.
Can you brief over just like what are some symptoms that signs or symptoms somebody should look out for that would indicate to them that they should be using the naloxone on someone?
Are you asking what sort of an overdose looks like?
Yes.
Yeah. So usually, what an opioid does is it slows down your breathing. And so, low or shallow breathing. If people are not waking up, people's lips tend to turn blue. So they're literally losing oxygen, right? Because their breathing slows to the point where at some point they will stop breathing, which is why rescue breathing becomes so important. They're unresponsive. Usually it helps folks do a sternum rub. So rub their sternum really hard. So if they're sleeping or they're napping or whatever, usually a sternum rub is going to, wake them right up. But if they're overdosing and if you call their name and they're non-responsive, and it's hard because that could also be, 1,000 different other medical things. But if you think, the person might have a history of substance use disorder, or you're looking at the scene and you're seeing maybe there's paraphernalia around. So think about that. And again, if you're not sure, always administer naloxone. There are no negative repercussions for doing that, and you might just save somebody's life. And if it's not an opioid overdose, you at least tried, right? You did something. And again, administering naloxone and then calling 911 is super important because if it's not opioid related or it's not even an overdose, you still want the paramedics to be there to be able to take over the situation and provide treatment to whatever the person may be experiencing.
Yeah, I think that's something that is so important for people to understand and really, really grasp that concept that even if you have an inkling or any kind of thought that someone could be overdosing, that it is okay to use it even if they are not, because I think that's what's so great about having something available to us like that, is that it like you said, it will not harm somebody if it is not an opioid overdose, but if it is, you are potentially saving their life. I do have a question. Are there instances where people have administered naloxone and then, it potentially was, something that just didn't work? There wasn't enough, or it wasn't enough for the person to survive?
Oh, that's a good question. I don't know. I'm sure there probably are instances, especially if the level of opioid in the system is very high. I mean, if you look at the naloxone, if you ever seen them, they're tiny doses, right? They're pretty small. It's not a whole lot of naloxone. It's not like a drip, right? It's just one kind of spray and you're done. So I don't know, but I would assume there's probably instances where if there's enough opioid in the person's system, it's possible that, the naloxone might not work. But I'm pretty sure the naloxone, what it does is it kicks off the opioids off of the opioid receptors in your brain. And I'm pretty sure it has a higher affinity to those receptors than most other opioids, if not all other opioids. So it basically kicks off the other opioids and it stays on that opioid receptor. And so it blocks the opioids from coming in, but that effect only lasts for 3 to 5 minutes, which I think is why folks then can re-overdose if, they're not connected to care pretty soon.
So I wanted to say, I hope that people listening, I want to make sure that they know that I just want to make sure they know that resource for where they can look to get naloxone.
Opt-in, OPTIN.
OPT. Perfect.
Yeah, so when you opt into something,
Oh,
so
got
opt-in,
it.
yeah, yes, .in.gov. And I don't know where the name comes from, but that's what it's always been.
Okay. So yeah, if you are listening to this and you want to make sure that you have naloxone on hand, please check out optin.in.gov. And then also, I think it's important for you to connect if you are in an area where you have one. Connect with your community coalitions. Your coalitions have a plethora of resources at their fingertips that they can give you. I know that we try to stay pretty up to date, obviously, on the resources in the area that community members might need. So, yeah, reach out to your coalitions and kind of start those conversations, and you'll find out so many resources in the area you didn't even know about. Because not only are we, I guess kind of to not to get too off track, but when you are administering naloxone to a loved one or somebody obviously there may be a second need there. So treatment, knowing the resources in your area for that, so that when they do get released from the hospital and they get the all clear, you can support them in a way that might help them work towards living in recovery. So yeah,
Mm-hmm.
connect with your community coalitions. It's so important. So Claudia, I just wanted to ask because we're just about out of time, so I wanted to make sure there wasn't anything else that you really wanted to share with the listeners today before we finish out here.
No, I think we touched on everything. Thanks.
Awesome. Excellent. Thank you again, everybody, for listening to Matters of Substance. You can check out our Instagram page for updates about shows that are coming up. And then also, you can listen to us on Spotify, iHeartRadio, Stitcher, pretty much anywhere you listen to your podcast. So thank you for joining us today, Claudia. And we just really appreciate it.
Thanks so much for having me.